Okay, everybody, in respect for your time and in the interest of not waiting around anymore, I'm going to get started. So I'm Chris Morrow, and I want to welcome you to our very first session in what we're calling the Island Dermatology Series. This is put on by PEP, Physician Education Program through Island Medical Program for you guys. Um, we did a island-wide needs assessment a couple of years ago, if you may recall, and dermatology was the number one topic for everybody across the board. It was quite impressive. So we're excited to say that we have actually 140 people registered, indicating that they wanted to come today, and from all over the island, up and down. And shout out to somebody from Kelowna as well who's joining us. And just take a moment to acknowledge the lands that we are lucky enough to be working and learning on, and also maybe give a thought to Indigenous knowledge as well. Um, some of us are in Coast Salish territory, but there are others. But I did a little looking around, being curious about what, for thousands of years, what some knowledge that was gained for skincare by the indigenous people. And there's a lot of it. So they used Western red cedar for dandruff, atopic dermatitis, and it was found to decrease bacterial load on the skin. Bearberry was used for melasma and solar lentigos, and seaweed, acne, and wrinkles. So I think we should all go get some seaweed and fix our wrinkles. And also witch hazel for diaper dermatitis. So those are some interesting thoughts, and maybe we'll learn some things today that we can also share with our Indigenous patients as well. We're going to use Slido today for questions. We have so many participants that questions will be done by Slido. If you're having difficulty with Slido, you can post in the chat as well. And we're going to do the question session at the end, which I'll be moderating. For the duration of the talk, we'd love it if you could have your camera on. It's pretty unnerving and difficult to give a chat to a bunch of black boxes and you don't know what people are thinking or doing. And it's also nice for us to have some community, even if it's on the Zoom. It's kind of fun to have the island together. So audio muted if you can. Without any further delay, I'm super thrilled to introduce you to Dr. Gabriele Weichert. I had to shorten all the amazing things I wanted to say about her just for time, but she does have a degree in biology followed by a PhD in physiology at Waterloo, and then she completed the dermatology program, the Royal College program at UBC. She's an instructor with UBC Dermatology and is active in teaching new graduates and learners in clinical practice. Her focus is on general medical and surgical dermatology and a little bit of cosmetics as well. She's the medical director of their clinic Skincare West, which I'm hearing from many people is very highly regarded as providing excellent dermatology and patient care. And she just happens to be the vice president of the Canadian Dermatologic Association. So I think we have a qualified speaker today, and I'm excited to hear from Gabriele about acne. And I'm going to hand it over to her. Thanks for showing up today, everybody.
Thanks, Chris. You can hear me good? Well, yes. I hope the good weather. Everyone's enjoying it, but I understand if not everybody's able to come as a result because it's such a short season for us. I'm going to try to share my screen and we'll get started right away.
Gabriele, the one thing in the chat, the Slido link is there for you guys. Yep. And if you're using your phone, you can put that code in. But if you just click the link, it'll take you directly to Slido. When you have somebody asks a question, it'll show up there. And if you like that question, you can put a thumbs up by pressing the thumbs up, and that'll vote the question higher. So that it'd be more likely to be one of the ones that we address. And I'm sorry for interrupting, Gabriele.
Yeah, all good. Okay, I'm just going to get started because I tend to talk a lot and have a lot of slides. So we'll move forward. Nope. I'm unfortunately not advancing suddenly. I think I just have to click my mouse. Okay, I figured it out. So as for disclosures, I'm a consultant, speaker, investigator for several pharmaceutical companies in the dermatology realm, and most of them are listed here. My objectives that I presented several months ago when Chris first asked me to do this are the following, but really I just hope to present to you the entire menu of acne treatments, and everything I discussed today, I hope, are things that you may be comfortable doing in your own practice. There's nothing in the acne spectrum that I feel is really in the realm of absolutely just a dermatologist. So that's a nice thing about this particular diagnosis. So just moving forward, I'm going to present 3 cases, and I'll be using it as a springboard for discussing the different acne management groups, sort of thing, what to think about. And so in each case, I would love it if you would just think about what you may find maybe a little bit challenging in this case. And Chris is going to collect those chats in the chat box, and then I would use it as a bit of a springboard for discussion. So in this case, we have a 15-year-old male. He's just developed acne within the last year. He doesn't have any scarring, especially, but there is hyperpigmentation because of his skin type. He's not tried any previous therapies, and in his family, there's no, special insurance from covering for medication. So if you were to think about offering treatment to this patient or other pieces of managing him, what would be like 1 or 2 challenges you would think of? And I'm just going to give you like 20 seconds to just rapid fire throw this into the chat box. And then Chris will share those with me on the side. And then we'll start talking about management a little bit. So just 1 or 2 thoughts about what would be tricky in treating a 15-year-old boy with this kind of acne. I'm having Chris and I realize that I don't see the chat box easily, so he's just going to throw those at me whenever he's ready. Yeah.
Yeah, we have scarring, compliance, cost, hyperpigmentation. Needs to be a simple regimen, therapy compliance, lots of cosmetic result after treatment, hyperpigmentation as a concern.
Okay, those are all really important thoughts. Thank you. That's terrific. So I agree with you. So in this case, there is a significant degree of hyperpigmentation. Some of that is active acne and some of it is not. And so the pigmentation piece is often perceived as the acne piece, or even scarring by families or parents. And then, of course, there's the cost of treatment because some acne treatments are fairly expensive. And then there's the compliance, and the compliance is hugely important. It's not uncommon for me to be referred a teenager like this patient where the boy doesn't even really want to be there. It's really the mother might be driving the referral because she's thinking, you may not like your acne, but he's not, a bit ambivalent about it. So there's sort of parent versus child, and there's also, males versus females. There's not always a difference, but there sometimes is in how they feel about their acne. So these are all pieces to consider when choosing the right treatment. So in this case, this is going to be a topical patient, and I'm going to talk about the major categories in treating with topicals. We have 3 major categories: the benzoyl peroxide, the retinoids, the vitamin A creams, and then the antibiotics topically. And so these are the 3 major circles. And the next layer is what are the different products within those circles. And so benzoyl peroxide comes both in a gel and a wash in different percentages. In the retinoid department, traditionally, we always had tretinoin. It's been around for about 30 or 40 years, and it comes in different concentrations. And then about 20 years ago, adapalene was a new retinoid that came out. And then most recently, we have trifarotene, which is a new novel retinoid. It's been marketed heavily for truncal acne. And then most recently, we have tazarotene in a unique concentration with a unique topical base that's really highly tolerable. So that's a bit of a new kid on the block as well. And then we have the topical antibiotics. Clindamycin and erythromycin don't come in a commercially prepared preparation, but they're sometimes compounded into other preparations. And dapsone is a commercially prepared product in a leave-on gel. And then moving forward, we have overlaps where these different categories are combined in commercial products. So at the top, we have benzoyl peroxide and a retinoid together. And in this case, I put in the product names just for ease of recognition. And we have Tactuo and Tactuo Forte, the Forte being a slightly stronger concentration of retinoid. Moving in around the corner to the retinoid antibiotic combination, we have tretinoid clindamycin. And then around the corner for benzoyl peroxide combined with an antibiotic, we have 2 products that are kind of exactly the same: clindoxil and benzaclin, benzoyl peroxide mixed with a clindamycin. So that's helpful as well. Moving forward, these starred products are on BC Pharmacare formulary. nothing else is in these boxes. So that's something to just be aware of if you have a patient whose coverage would be under formulary, that these are things you can reach for. And these are a couple of other stars. The first of all, I think cost is a really important piece for our patients because some of these products are really expensive. The least expensive is the benzoyl peroxide. The most expensive are the ones I've put stars beside. And so that they can sometimes be upwards of almost $200 for a tube of these topicals. And that's unreachable for some families to use those, to access those costs. So there's just to talk about the topical treatment ladder. Is cost a concern? I'll say to patients, do you want something that's maybe $20 or do you want something that might work a little bit better, but it could be $70 or even $100 or maybe even $150? And so if cost is a concern, I always suggest over-the-counter benzoyl peroxide first, because that'll be about $20. And they can either choose from a topical gel that's a wash, a topical wash that is just washed off, or they can choose from a leave-on gel, but it's going to be fairly low concentration. You can also prescribe benzoyl peroxide in a higher concentration, but then it would be by prescription. Is a prescription possible or something that could be accessed? Always start with a retinoid. The best data is with topical retinoids because they actually target 3 of the major 4 acne pathophysiology pieces. So if you can, that's the best thing. And in terms of prescribing a retinoid, there's a couple of tricks. It's a bedtime application because some of the retinoids are actually degraded by sunlight. So it's an evening thing. So it's on overnight. It's really, really important for tolerability that they moisturize their skin first. And that might seem counterintuitive that you're adding sort of oil or grease to the skin, but moisturizing first incredibly increases the tolerability. It reduces dryness, and they'll be able to have more compliance. I do discuss compliance when it comes to long-term treatment, and I'm going to show a graph about that in a moment. You have to kind of stick with it, obviously. So I say 3 months would be at the minimum before I want to talk about whether this works well with you. And, you can encourage like a baseline selfie, something to just show where they started at, because they don't always appreciate where they've gotten to. And after 3 months, if we have a look and we're not feeling like it's as good an improvement as we'd hope for, then you can add a class. So for example, if I started with a retinoid and I'd like to add a class, I'll add a benzoyl peroxide clindamycin combination product. And now I've got all 3 circles in the categories working for me. Or I might just switch to a retinoid benzoyl peroxide combination product. I'll often do that if they've run out of their retinoid, if they're close to running out, then instead of giving 2 new prescriptions, I'm just giving 1 new prescription. So that's how I would approach that. I always like to show this chart. This is an old chart that I just grabbed from the internet about tretinoin, which is a molecule that we don't use that much more in acne. But I just like this. I like this graph because we're not very patient anymore, for sure. People want instant gratification. They want their Amazon package in 24 hours, and they want their acne to be gone within a week. And that's just not how these medications work. So I'll often kind of draw this graph just to show that, in a month, in 4 weeks of using this with great compliance, you might expect about 20% improvement. And that's not very impressive when you're a 15-year-old teenager who really just wants their acne gone. It's important for them to understand that this curve will continue to improve their acne to 12 weeks and even beyond. And that's why that compliance is really important. Don't just chuck it in a drawer quickly after a month of using it, because it does require that duration of therapy. I just think it would be interesting for all of you next time you go to a drugstore to go over to the acne section and see what kind of chaos it is for the consumer to find the product they're looking for. So if I suggest a patient that maybe benzoyl peroxide over the counter is the best choice for them, and then they meet this acne aisle in the drugstore, and this is what it looks like. These circles represent the only products on the shelf that contain benzoyl peroxide. Everything else on this shelf are either cleansers or salicylic acid as a topical ingredient, which is barely anything to add to the acne management. And I think there's a certain degree of shame also for the consumer to look at this aisle and think, well, if I really cared about my acne, if I really was clean, I would buy a cleanser, I would buy a few of these products and get a collection together. And that is unnecessary and a waste of money. If they're going to use a whole bunch of cleansers in the acne cleanser department, they're actually going to get a lot of dryness in addition, and it's difficult for them to tolerate the medicines that are actually doing most of the work. So I usually write on a piece of paper or a little notepad, benzoyl peroxide, and I hand it to the patient. I say, walk this up to the pharmacist and ask them to show you where that product is on the shelf, because this is very confusing for them. Okay, next case. Here we have a 32-year-old female, long-standing acne since teenage years, has had her children, no more planned. She does explore, she admits to that she's a bit of a picker, and she's so sick of her acne. Right away, when you're thinking, how am I going to manage this patient? What are some challenges that you're thinking of in this case? What are you wondering? Like, how am I going to approach this? What are some challenges that you might be thinking of as you're coming up with ideas on how to offer her treatment?
And again, just put your thoughts in the chat, please. So we have childbearing age, scarring, jawline acne, management of previous hyperpigmentation and scarring, the picking, how do I handle that? Hormones versus retinoids, question mark. How do you change the picking habit?
Hmm. Great. I mean, all important thoughts, for sure. That's terrific. All the things I find challenging as well, for sure. So yeah, challenges in this case, I often find the expectations are very high. If an adult female is coming to you for acne management, she's done. Even and men too. They're ready for this to have for there to be a solution. There's frustration about previous therapies. It's chronic. You can't say to them, by the time you're in your early 20s, this is going to go away, because it hasn't gone away and it's not going to go away. So there has to be an approach that could be definitive, and that would be really preferred. I do find that in the adult years, topicals are much less tolerated because people's skin isn't as oily as they are when they're teenagers. So that's tricky. And women of this age generally want to avoid oral contraceptives, even though they can be quite effective. So they're not really, if she's not planning more children, and perhaps, she's got an IUD, say, or her husband's had a vasectomy, like, she doesn't really want to go on the pill at this point. So some of the things we think about in the teenage years aren't something we reach for as much. So these are the things I do find tricky. So in her case, what would I do? I would try topicals if that's what she'd prefer, probably with less frequent application, because, she's going to get more dry. So I might say you're going to start with twice a week. And then if you are able to tolerate it, work it up to daily if you can. But if not, take some days off in between. Topical dapsone gel may be more tolerable. When they presented the data on topical dapsone when it first came out, the group that had some of the better improvement was adult female acne. So it might be more tolerable in that group in particular, and effective. I really like oral spironolactone in this age group, and I'll talk more about that in a minute. Isotretinoin, Accutane is still a good choice, either at regular low dose protocol, and I'll talk about that. And then device-based treatments, it's not what I recommend as treatment, but oftentimes part of the conversation is an expectation about what can I do to make things look better with time, and curious about what kind of devices could be used in that realm. The picking piece is tricky. I think just discussing it is helpful, because just giving them the information that every time you scratch off the surface of an area that's healing, you're actually re-wounding it, and it's going to take even longer to heal and create more pigmentation and potential for hypopigmented scarring and whatnot. So just that education piece, and most people are aware of that, but just a reminder is always nice. So let me talk a little bit about spironolactone. Spironolactone is good actually for all types of acne, not just papules, also comedonal acne. It can improve that as well. You really need about 4 to 5 months of ongoing treatment to sort of see where the optimal results are for any one patient. And I don't have the resource printed here, but this is pulled from a paper that I've used in other talks, where about 85% of patients will report anywhere from 50 to 100% improvement on spironolactone, and 15% won't. But 85 is pretty good, I find. I do feel that the dose is usually around 100 milligrams. That's kind of the sweet spot. You can go up to 200. That's usually used more in hirsutism, but it's a little more difficult to tolerate. This is only to be used in females because men will develop gynecomastia, and I don't use it in somebody who may potentially be planning a pregnancy, because it can cause feminization of a male fetus. But I don't do pregnancy monitoring. I just say to people, if you're planning a pregnancy, this is not the medicine for you, and if you do get pregnant, you should stop. But it's not like a teratogen. It's just that I think into something like, I don't know, the third month of gestational development is when there could be a risk if they were still on it. About 7% of people stop because of side effects, and they are listed here. I don't really find them to be a big deal generally, but some people do stop. And hyperkalemia was kind of wandering around the literature, 10, 15 years ago, but there's been lots of great studies showing that if a healthy person has normal renal function, there is no need for blood work monitoring at all. So that's really good. New idea, teens and spironolactone. Again, females only. And in this particular paper from 2021, it was a little bit of a shorter duration of treatment, but about half the patients had 50 to 100% improvement on oral spironolactone. Same side effect profile. It was generally well tolerated. And it's a nice alternative to oral antibiotics. People who aren't quite ready for isotretinoin or perhaps don't want to take the oral contraceptive pill for whatever reason, it's a new idea. I actually put my 16-year-old daughter on spironolactone, and she's tolerated it really well for acne, and I think it's working pretty well as well. And she's not too big. She's about 120 pounds, and I started her off at 50, just making sure she could tolerate it, and she's at 100 now and doing fine in terms of tolerance. So oral contraceptions, of course, oral contraception is a good treatment for acne as well. It's the low dose estrogens and low dose progesterone that works fine. Sapropterin acetate is an androgen blocker, so it's probably a little bit more effective as a birth control pill for helping manage acne. It takes at least 3 cycles to see a change, and then about the maximum improvement will be about at 9 months. And of course, if a woman or a teen comes into my practice and they have been flaring, especially, I'll always ask them, has there been any changes, or were you on the birth control before? Because when they withdraw, they'll have quite a significant flare sometimes. So that's worth knowing about also. Okay, I'd like to talk a little bit about antibiotics. There's kind of a feeling that I think we're all kind of uncomfortable in using antibiotics for any duration now, long-term for acne, just because of all of the resistance to microorganisms to resistance these days, but also the gut microbe thing. And then also it's even been shown that the skin microbiome can take up to 2 years, to regulate after being on a course of acne antibiotics. So for lots of reasons, not the best thing, but these are the different protocols. Tetracycline, super cheap, but usually you have to take a fairly large dose, which should be divided. So that's 2 doses a day. My favorite is doxycycline, anywhere from 50 to 100 milligrams a day. And even better, I like the doxycycline 40 milligram slow release formulation, which is a trade name Aprolon. I like this preparation in particular because it's submicrobial. It only has anti-inflammatory properties, but it doesn't show any, it doesn't have an increased risk of yeast infections and such. It's just that it's more expensive. So it's about $90 a month as opposed to $15 a month. I don't generally prescribe minocycline because it's a bit more synthetic and it's associated with a lot more drug rashes, drug-induced lupus. I had a young woman I'm managing right now through a terrible drug rash. She was admitted to VGH for about a month because she almost went into liver failure from the minocycline that was prescribed for her rosacea from another doctor. So I've seen some pretty scary reactions to minocycline. So I generally just use doxy. Erythromycin doesn't work great, but for those people who are tetracycline allergic, it could be an option. And that's why we also have the trimethoprim sulfamethoxazole listed as well, although more drug rashes with that as well. So not preferred, but for people who are allergic to the others. So generally, I don't like to go more than 3 months in general. And after 3 months, I'll either, continue with a topical just to get over the hump of a bad flare, or upgrade them to isotretinoin or a hormonal target if we didn't already discuss that. And to use it in combination with other modalities just to kind of reduce the Propionic acnes bacterial load and reduce resistance in that as well. So these are options. Okay, progressing along here to a more significant case where we have a 16-year-old female. She has progressive acne. She has scarring. Her mom had severe acne, so it's in the family. Generally, they'll have tried things. She's tried a prescription cream. She's tried oral antibiotics. It wasn't a very impressive improvement. Mom's concerned that there's going to be liver damage. If we do isotretinoin, they're asking right away about scarring treatments. So in this case, what sort of challenges might you feel right away? What are you thinking? Oh my gosh, this we've got a lot to talk about here. What are the pieces that are rising to your mind right away that you want to start addressing in this case? And I'll give it a minute for you to throw me a few of those thoughts before I get into the things that I think about as well.
Yeah, and while we're waiting for those responses, somebody made a comment in the chat. They have seen terrible sunburns with doxy.
Oh, interesting. Yeah, that's absolutely worth mentioning. And interestingly enough, the literature doesn't support that super strongly as a super photosensitizer. So I will say to people, be careful, but I've also had very little trouble with it myself. So it's interesting that you had an experience where it was a difficult sunburn. That's interesting.
So I have lots of responses. We're worried about her mom's concern, the severity of the acne treatment. pregnancy concerns, her beliefs and her fears, um, nodulocystic type acne with scarring, may be resistant to isotretinoin, and pregnancy is an issue.
Mhm.
Navigating the parent,
Yeah. Yeah.
uh, fear of liver injury, scarring.
Yeah. All. I'm sorry. My cat is stuck in the room. I'm going to quickly let him out. I apologize. Right back.
That's one of the fun things about Zoom presentations. Your
Sorry.
life in the background gets into it.
I knew he was going to start interrupting us in a moment, so I let him out. Okay, so here we are. Challenges, of course. It's a matter of convincing, the patient and the parent, and together that isotretinoin in this case, I feel is the most important therapy to offer because it is the best therapy in this case. And if we get there too slowly, there's going to be more scarring. And people have an imagination that there are these magical scarring treatments, and there really aren't. Scarring treatment is very complex. It's extremely expensive. And so what we really want to do is control the condition so that scarring is minimized. And that's why I always, I'm very gentle with people, particularly when they come in with lots of feelings about this therapeutic. I want to be very respectful to their concerns, but I also want to say, this is the best treatment for you. I think you deserve to be offered it. Let me tell you more about it. And people do come in with a lot of myths and internet information about isotretinoin. So it's important to just walk people through those concerns one by one. And we don't have to get there right away. But sometimes it's just a matter of sort of, seeing that other things aren't working very well, and that there is something that I think is going to get you clear. And once you kind of, offer that little, that magic goal, then we do often almost always get there as in terms of buy-in. And there's this feeling right away, can't we get to the, people want to treat their scars and the marks before they've even, cleared the acne. And so there has to be an understanding that you have to clear the acne before you can start working on scar management, because all of the modalities that are used to treat scarring can't be done if there is active inflammation and acne in the background. So it's important to take care of that piece first. And I'll say, we're going to talk about more of that a little bit later. I'll tell you some more information when we get there, but no, nobody's going to treat you for your acne scarring until we get the acne managed. Okay, so I'm going to focus this whole next discussion on I misspelled it at the top. My apologies, isotretinoin side effects, just to talk about those a little bit. They are expected generally, but they are manageable. So absolutely patients will have a tendency towards dry lips, and that will be dose dependent. Dry nose, tendency towards nosebleeds, dry eyes a little bit, and dry skin. Definitely people who are prone to eczema or dry skin will have dry skin often on the backs of their hands and on their forearms. There is sun sensitivity, absolutely. So they have to be careful that way. We don't expect an elevation in cholesterol and triglycerides, but that needs to be checked. It is definitely a teratogen, and so strict contraception is important so that they don't get pregnant. And I'm very serious about that. Obviously, it's an important thing not to have happen. And I often say to people, this is so serious that if you were to get pregnant, we'd often recommend a termination of pregnancy. So you need to understand that we're going to have a really honest conversation about your relative risk and understanding what they need to do for birth control. And sometimes they'll have to go back to their family doctor to, talk that through to make sure that they're safe to get started. It's very rare, but possible. People can get myalgias. I often find that in very sporty people who are super physically active will have a bit more myalgias, possibly arthralgias. Hepatitis is extremely rare. In the cases that I've seen, elevated liver enzymes is often when there's been a recent viral infection, and sometimes mononucleosis, something like that. Night vision changes are reported. There's even reported permanent night vision changes, but I've never seen it. I think it's quite rare. The whole thing about mood disorder and depression hasn't really been put to rest. If anything, there's a global improvement in mood after being on treatment for difficult acne. And there was discussion about 10 years ago about inflammatory bowel disease, and that's been mostly put to rest as well. Okay, so in managing the dosing and prescription, you have to kind of eat the isotretinoin pie. You can eat it fast or you can eat it slow, but you have to eat the pie generally to get to the complete treatment and to be clear. So the faster you eat the pie may reduce the incidence of recurrence of the acne later on. So I generally try to aim for the highest dose that they can tolerate. And definitely if you slow down, reduce the dosing, they'll have fewer side effects, which is nice as well. Okay, so let's do some isotretinoin math, and this is where it gets busy. Traditionally, the total dose of isotretinoin you'll see in different publications is a total dose of about 120 to 150 milligrams of milligram per kilogram, and that was posted as how we manage moderate to severe acne. And this has been stuck in the literature for 20 to 30 years because this medication really came out to treat moderate to severe nodular cystic acne, and now we're actually treating patients who don't have such severe acne with isotretinoin. And so the total dose may not be as relevant for those patients who don't have as severe acne, but we don't have a ton of data to support that. But that's sort of the thought leaders will say things like that. You probably don't need to aim for that high dose if their acne isn't that bad. But this was the traditional range that we're reaching towards. So let's take this fellow. He's about 130 pounds. He's about 60 kilograms. And so I'll reach for a daily dose of 1 milligram per kilogram per day, but you can go lower. You can go lower to anywhere from 0.25 to 1 milligram per kilogram per day. But I try to get towards that 1 milligram per kilogram per day and see how they do. Because if I'm able to get them to that target dose, they're going to have about 5 months of therapy at that target dose. And that's kind of the shortest duration of therapy for a course of isotretinoin. So for example, if he's 60 kilograms and I dose him at 60 milligrams per day, 1 milligram per kilogram, and I do that for 30 days, and I do that for 5 months, he'll have taken 9,000 milligrams of isotretinoin. Now I divide that by his body weight. We're at 150 milligram per kilogram total dose, and I'm in the upper range of his total dose. So that's why we reach for that 1 milligram per kilogram, is to get that total dose in the system right away. So that's the most semi-aggressive way to treat with this medication. But I always think it's interesting. This is a photograph of competitive athletes that I thought was cute to discuss this. If you're going for that 1 milligram per kilogram per day, it kind of freaks people out when people are a little larger. It's one thing to sort of say, okay, here we have a 40 kilogram young gymnast, and then you have a 100 kilogram hockey player. And it kind of freaks people out to dose patients at 100 milligrams a day because it just seems like such a big number. So I see that a lot in patients that come to me from other places, that they've been underdosed because it's kind of freaky, I guess, to give somebody 100 milligrams a day of isotretinoin. But, that is generally very well tolerated in these larger people. So it just gives you the range of, different body sizes and what the dosing is going to be, because it's based on their body weight. Okay, so when I do a prescription for isotretinoin, it is monotherapy. They can stop all of their other treatments, including their acne cleansers. And that's important because I don't want them using a bunch of acne cleansers that are going to be drying and will make it difficult for them to tolerate the side effects of the isotretinoin. They will always have a baseline ALT, cholesterol, triglyceride, and a pregnancy test if they're women. I do monthly urine pregnancy testing for anyone who identifies as, well, not just identifies as being female, but anyone who has a uterus, anybody who could get pregnant. I'll do a monthly urine pregnancy test, regardless of their gender status, their self-reported gender status. And at 2 months of treatment, I will repeat their ALT and cholesterol, triglyceride, their lipids. And if I'm not going to change their dose any higher, there's no more blood work required. This has been in the literature now for about 8 years. Baseline blood test, 2-month blood test. And if you're not going to change the dose upward, there's no more need for blood work for transaminase and lipids anymore. So that's really great for patients. But again, monthly pregnancy test in my practice. When you prescribe isotretinoin, it comes in these 4 capsule sizes, 10, 20, 30, and 40 milligrams. And so that's a bit awkward because if you're dosing towards a 1 milligram per kilogram body size, then you need to start doing multiples of those capsules. I generally do say take it with your biggest meal of the day. And if that biggest meal of the day is a huge bowl of oatmeal that doesn't have fat, that's not helpful. So take it with dinner. That's usually a meal that's fatty. And if they forget because they're teenagers and they're busy, I say grab a spoonful of peanut butter or ice cream or high-fat yogurt and just swallow your tablet with that. And now there's new formulations that are better absorbed. And I often find that patients are being substituted that particular preparation anyway, because it's almost as expensive as the original formulation. So for example, if someone's target dose is 60 milligrams, I'll give them a 30 plus 30. Or if cost is a big issue, I can have them take a 40 milligram tablet one day and 40 plus 40 or 80 the next day. So 40 alternating with 80, average is 60. So that's kind of a 60 milligram dose, because each capsule size is exactly the same price, regardless of how much isotretinoin is in it. So if they take a 10, it's the same cost as a 40 to the consumer, to the patient. So, and if they're a 100 milligram patient, I'll go like 40, 40, 20 and per day, and they can swallow it all at once. Okay, so a little bit tricky with knowing those capsule sizes, but it'll come up in your EMRs as you go to prescribe what the different capsule sizes are. It should be pretty straightforward for you. Low-dose isotretinoin. This is becoming much more popular with time. It's kind of like eating the pie slowly. Definitely fewer side effects, especially the dry lips. People really enjoy not having that be a big problem, but you're going to need to monitor for longer for sure in females. There's going to be that monthly pregnancy test that is important. And then there's more appointments, because there's a monthly need to review the pregnancy test and send the monthly prescription, because I generally don't prescribe for more than a month in a woman who I have to monitor pregnancy for. I would say that about 1 in 5 female patients don't do their monthly pregnancy test, and I have to chase them around for that. So that's something that I'm really, I require a lot of compliance on. And then the low dose isotretinoin, there just might be more chance of relapse, even with a full course of isotretinoin. So those are the downsides with withdrawing at the treatment a little bit longer. So a couple of tips on managing isotretinoin. First of all, they need buckets of lip balm. They'll need lots and lots of lip balm. I like Aquaphor. It comes in little lip squeezy tubes. Aquaphor is kind of like a Vaseline preparation, but it's a little thicker, so it has some staying power, whereas Vaseline kind of melts on the lips and doesn't stick around as long. Having a good moisturizer important, and I do encourage them to moisturize, any thin moisturizer. And patients always want to know, what moisturizer do you recommend? And I don't recommend any one moisturizer, because there's tons of great moisturizers out there. Anything they like is fine with me, as long as they're not having a reaction to it. But unscented eczema type moisturizers are often the ones that are tolerated better. There's some nice data that omega-3 capsules will reduce the dryness and the cheilitis, and so they can get a nice big bucket of the omega-3s, take one every day. And I really do find that if you continue the treatment until they have a full month where there are no new acne papules, then you're going to get better chance of no relapse. So I'll continue to treat month by month towards the end of their treatment. If I feel that they haven't achieved clearance, and I always see them towards the end, if they said, yeah, I still got a few new ones this month, then I'll go another month and have them back another month until I feel like they've gone a month where there really isn't any active acne, then I'll stop. Minor blood work changes are okay. I'll often see patients having had their dose lowered or even stopped their treatment because there's been some relatively, what I consider, minor changes in their blood work. So it's okay to continue if their transaminase levels are approaching up to 2 times normal. That's okay. I'm not going to necessarily change their dose. I'll do blood work again, but I'm not going to necessarily change the dose. Cholesterol may elevate a little bit, and that's often more common in patients who have familial hypercholesterolemia. It might be unmasked a little bit with this treatment, but it will go back down after they've stopped treatment. It's the triglycerides I'm more interested in, because it's a risk factor for pancreatitis. But as long as the triglycerides are under 5, I'm okay. And even, sometimes they'll even double. If they started off at 1 point something, they'll go up to 2 point something. That's no reason to change anything. I would repeat them, but I wouldn't change the dose. I just push on. Now, it's okay for them to consider scar treatment once the acne is getting close to clear. There's been a concern in the laser literature not to treat patients with laser treatments like ablative laser while on isotretinoin, and that's actually been put to rest about 5 or 6 years ago, that people can start scar treatment when they're still on treatment or just after stopping treatment. But again, they should have mostly no acne anymore, because they can't treat on top of active acne. But if they're eager to start, it's okay. Now, in terms of reducing the chance of relapse, I do have patients go on a topical retinoid immediately as they finish their isotretinoin treatment. I'll give them a prescription for a topical, have them do a thin layer once a day everywhere they did have acne for 12 months. And I find that reduces relapse. And being on the oral contraceptive pill also reduces relapse by quite a bit in women, obviously. Couple of little extra thought for you here. I use the British Association of Dermatologists website for a lot of their free patient information leaflets. So you just need to, check out this link, click on patient information leaflets, and they have great patient handouts for almost every common dermatological diagnosis and therapeutic. And we actually have the isotretinoin handout from this website in our EMR. This is our patient handout before they start treatment. It's really informative. It's not heavily based on side effects and litigious issues like some American resources. They can even take a scan with their phone of the barcode here to have it pop up on their phone. Sorry, was there a comment? We're good? Okay. So I really like this handout. Post isotretinoin predictions. I say to patients, after you've finished swallowing this medicine, you're going to be clear. You're going to be clear for about 3 to 6 months. And after that, we'll see where you are. I call it the 1/3 rule. So 1/3 of patients really won't need any meaningful acne treatment again. 1/3 will need some treatment. They might need some topicals. They might want to go on the birth control pill because of mild recurrences. And then about 1/3 will have some significant areas of recurrence, often fewer papules than they had previously, overall fewer numbers of active lesions, but the lesions themselves are active enough that they would be eligible for repeat isotretinoin. And I think my record is a young man that I had go through 4 full courses of Accutane isotretinoin in his teenage years until he topped out around the age of 20, and then he remained clear after that. So sometimes you just need a little more. Okay, if you don't use isotretinoin, these are some before and after pictures. It's a very impressive therapeutic. It's super gratifying to see these teenagers and adults who are just like super frustrated with their acne ultimately achieve clearance. They're just so happy. And particularly that teenager who's really struggling with a whole, ton of acne. It's really demoralizing and depressing and such self-esteem issues. So it's such a magical therapeutic. And if you're thinking of prescribing it and want the confidence, I would encourage you to give it a whirl because it's great. Okay, if you like guidelines, this is the last guideline I found, and I think 2015 isn't really recent, but I don't think there's been a huge change in therapeutics, to be honest. And if you like guidelines, here's a nice flow chart. If you want to look up the whole paper, it's the CMAJ 2015 acne guidelines. It's the most recent Canadian guidelines, and it takes you through everything I've talked about in sort of a flow-like fashion, and then you can kind of reach backwards, to hit up those different exact prescriptions as you move along. So that's what I prepared in conversation. I feel like I went through it pretty quickly, but I'm certain there's lots of small questions about finessing some of this. One of the questions Chris brought up earlier, because it was a pre-question to the talk, was what do you do for acne scarring? Like what exactly is being done these days for acne scarring? So I'm just going to launch into that question as other questions potentially arise, and so to talk a little bit about the data for what works best for acne scarring. And there's 3 major categories to know about. One of them is fractional ablative laser treatment. The next thing, which has become more popular and is probably almost as effective, is something called radio frequency microneedling. And these are little stabby needles that go into the skin with this machine. And as the multiple needles enter the skin with this applicator, they'll run radio frequency energy into the needles deep when they're in the skin. And this causes some collagen shrinkage, but also triggers some collagen neogenesis and can improve acne scarring as a result as well. And the final thing is just what I call plain old microneedling. So microneedling is a little motorized wand that has about 12 or more needles in it, and it will go through a piston-like effect in stabbing the skin very quickly with these multiple needles. And this wand is swept around the face in sort of back and forth or circular fashion, and you're basically stabbing the skin with these tiny little needles, and you're inducing micro injury and inducing collagen production by waking up the fibroblasts through injury. Fractional ablative laser and radio frequency microneedling are expensive. You're looking at probably $2,000 to $5,000 for a course of treatment that creates meaningful change for the patient. Plain old microneedling isn't as expensive, but requires multiple treatments, maybe up to 6 or more, to get to the same result, and may not be quite as impressive. And I do encourage people, my patients, if they're looking to proceed with some of these treatments, that they seek out a very reputable clinic that has a medical director associated with them who understands the devices and understands the outcomes, And I have good people to recommend, my colleagues in Vancouver and Victoria, who do some of this work. And to mention one extra thing before we get into other questions, there's a new device whose name I forget exactly the name of it, but there's a new laser that's being marketed. And I have reputable colleagues who have purchased these, but it's a new laser that is meant to treat acne because it shrinks the sebaceous gland down to nothing, and apparently can be really effective at treating active acne using a laser to shrink the oil glands. Again, talking a couple of $1,000s for the patient for those applications.
Amazing. Thanks, Gabby. So much awesome information right off the bat. So I have some questions. Feel free to put your questions in Slido, or if you're having trouble with that, use the chat. So the first question, since we're talking about Accutane, is could aldactone be used post-Accutane treatment?
Yeah, it definitely it could. So I guess it's a question of, how much recurrence do you expect? And we just don't know in any one patient what the recurrence is necessarily going to be, because you don't know which one of the 1/3 they're going to be. But there's a 2/3 chance they're going to have some recurrence, and only a 1/3 chance they're going to be forever clear. So yes, you can use the spironolactone as your kind of post-Accutane plan, your post-isotretinoin plan, to carry on with for a time until you or the patient feel, let's try to withdraw it and see what's underneath this. And you can always restart it if you want down the road. So if there's a high motivation to have great clearance, then perhaps do it for 6 to 12 months, and then maybe half the dose and see half the dose again, because you can easily take 25 of spironolactone and just slowly pull away, depending on how motivated the patient is to be clear.
Great, awesome. And just to flesh that out a little further, there was a question, what's the duration of spironolactone? Is there one?
That's
or
tricky. It's kind of
yeah,
indefinite. In adult female patients who love it, they kind of just almost take it into menopause. Honestly, like they can take it for a long time. And yeah, so there's no duration of treatment.
great. Um, Another question is around Accutane. So for older patients who are more compliant with a uterus, or those on 2 forms of birth control, do you still require the monthly pregnancy test?
Yeah, that's such a tough one. I think it's a really honest conversation with the patient. If you have a mature patient who cognitively understands how serious it is that if they were to get pregnant, that termination is, I'll say these are serious birth defects. And, oftentimes if I get them, oh, absolutely, I'm not planning to get pregnant. If I were to get pregnant, I that would not be on. And so it's tricky. It's a comfort level for you, whether you're comfortable prescribing, say, 2-3 months at a time, and then sort of saying, it would be good to do a monthly pregnancy test, but I'm not going to pull you in and only give you 30 days of prescription. Maybe if you have like a very compliant patient who is doing all the right things, you might want to, go every 3 months or so, but that's really up to you. I think I can't say that I have exactly one way of doing it, because it's extremely patient dependent. When you have a reliable patient in front of you and when you're a bit nervous. And that's your call, right?
Great, thanks. So we have a lot of detailed questions about Accutane, but before we do that, I'm going to change gears a little bit. Are any dietary considerations around
Yeah.
acne? Do you counsel about diet?
I definitely breeze that over. My bad. But there's been 2 things thrown around. I'm sure you might have seen them in the last sort of 15 years: dairy and sugar. And so these are 2 things. Probably sugar is the stronger association. So it's the simple sugar consumption may be pro-inflammatory, not just for skin, but also for lots of things. And so I will bring that up with people. I also, talk about dairy a little bit. And so dairy, it's not the fat in the dairy, it's the dairy in the dairy. And actually the strongest association with skimmed milk products and acne. I'm also very, it's a tricky thing for me, because I think teenagers don't love not eating sugar. And also we've had some experience with eating disorder in my extended family. And I think giving a really heavy messaging on guilting teenagers about their diet can also be detrimental in some cases. I bring it up, I keep it breezy, but I say things like, dairy might be a factor. You might want to, there's lots of ways to eliminate dairy and use non-dairy products, and sugar might be a trigger. So, the less refined sugar you eat might be better for you. But those are the two pieces that we might know about.
Great, thanks. And do you ever inject a larger acne nodule or cyst with steroids? And if so, when would you do this?
Today. Yeah. Yeah. So I do it often. It's tricky because I don't have a practice where it's easy to just like hop on over when you have a bad acne cyst. It's tricky for me to offer that. But yes, I do inject acne cysts with steroids, particularly if they're having a really terrible acute acne cyst, and I'm worried that they're going to scar from it. So yeah, I do interlesional Kenalog injections, and I don't like to do it more than a couple of times in one cyst because you can actually cause atrophy, which sometimes isn't reversible. But for the really boggy, palpably kind of boggy cysts, I will offer injection in those. And the concentration that I use depends, but I would say that if I'm going to say it out loud to a large group, I would say I would go no stronger concentration than 5 milligrams per ml as a dilution factor.
Awesome, thank you. And you think it's appropriate for non-dermatologists to do that?
Yeah, yes, why not? The trickiest thing I find is that we have really teeny tiny needles in my practice. I have 30 gauge needles, which we use, but I know that most offices don't. And that makes it a little harder because it's a lot more painful for patients using a higher gauge needle. And then you might also get a lot of the same fluid leaking out of the pinpoint hole if you use a larger bore needle. So the smallest needle you have in your practice is the best for those. And I would say, inject one particular cyst, maximum twice. And if it's not working, you should also be thinking, what else can I do to help with the acne in this case?
Great, thanks. Would you ever use a combination of a contraceptive pill and spironolactone, or would
Yeah,
that
I've
be
done it
redundant?
lots. Yeah. Yeah. Good
Yeah.
question. I think if they are very androgenic in their sensitivity, like let's say they just have their receptors are very sensitive to androgens, or maybe they have a lot of androgens, then in those cases, yeah, absolutely. I've doubled down on that.
Great. Okay, I think we have mostly Accutane questions now. Except for the one question, who do you recommend for the scarring treatment? Do you want to say that now, or do you want to share it another way?
Yeah, I'm happy to share that. So two names I'm going to just throw, and they're not the only ones, but these are two names that I know and respect well. One of them is Dr. Vincent Richer. It's pronounced Richer, but it's Richer at Pacific Derm in Vancouver. He's terrific. And a separate clinic to that is Dr. Allison Sutton on Broadway in Vancouver. And in Victoria, there is a clinic called Cosmetica, which was run previously by Dr. Mark Lupin, also a dermatologist, but there's been some shift in ownership there. So I can't speak as specifically to the ongoing medical oversight there.
Great. Amazing. Thank you. How are you doing answering all these questions?
That was good.
Okay, good. Okay, because we got some more. So I actually found a couple in the chat as well. So as we go into maintenance with spironolactone, is it advisable to reduce it to a minimum needed dose or decrease the frequently to 2 to 3 times a week?
So that's been played with a little bit. It's a great question. I know, and I guess the question is why less? Is it a matter of tolerability, or just people don't want to swallow so many things? And so those are two different questions. If it's tolerability, yeah, I would move down a little bit faster. There's also been some protocols where you just take it during that kind of flary time of your monthly cycle. So that would be, usually around your estrogen spike. So kind of taking it for maybe mid-cycle for 2 weeks and not for other 2 weeks. That's another option. I've seen protocols like that. I don't do it that way, but I don't know how well it works. But that's been published as well. So yeah, I mean, you can sneak it down and then just see how they're doing. I think the patient will know within a couple of months whether that continues to work well or not. And then to play with episodic versus daily dosing.
Great. Awesome. Okay. Some interesting questions here. So spironolactone is a banned substance for sports.
Oh, I didn't
Can
know that.
high, because it can mask other things, I think. Can high level athletes get a medical exemption?
Oh, I don't know. I don't know the answer to
Okay.
that. I've never been asked that question. That's interesting.
Nice. If somebody knows that answer, go ahead and pop it in the chat. Um, So young males take a lot of bodybuilding products. Are these associated with acne?
Yeah, I always ask that question. If I have a man who's in my office and they're kind of like they look bodybuilding-ish, and they have bad acne, I'll always ask them, number one, if they take anabolic steroids, and number two, if they use supplements, because almost all of the kids do now. They're like, it's so common. Any kid who's going to the gym these days has taken either pre-workout or post-workout supplements. Like they just do. And so when it comes to taking like protein powders and stuff, it's the whey products, because they're a milk product. I'll suggest, if that's still important for them to take a protein powder, that they switch to a vegan product that's plant-based, as opposed to the whey products. So those two pieces, anabolic steroids and dairy-based protein powders.
Great. Thank you. Um, okay. Just back to the scarring for a second. Treatment of acne scarring in the back in adult women, is that the same options or?
It's so hard. I mean, all of the same things work, but the area of treatment is so large that you're going to be charged for the area, and it's and there's prolonged healing. Like the trunk isn't as oily as the face, so healing is about 3 times as long in terms of coming through the side effects of the, let's say it's fractional ablative laser treatment, where they're basically skimming off the surface of the skin to get that, trigger the healing. So it'll work on the back. It could take 3 times as long to heal, just because of the lack of sebaceous glands and whatnot. And again, you'll just be charged by area. So it's just tricky. And then there's the blending. Like the face is sort of one cosmetic unit, but if you treat the back, you're going to have an edge to where you stop treatment. And there could be a kind of not a shelf, but like a line from where you start and stop treatment. So the treatment has to kind of be feathered, I think, to get good results. So it's really tricky on the back for sure. And then, you know what, for a lot of patients, they have to understand, after they finish isotretinoin, there's still a lot of residual erythema, and that's not scarring. So if they imagine all the redness to be gone and everything is skin colored, there's still going to be some textural changes, potentially some mild shallow scarring and some mild acne scarring. But if you just imagine, like, paint the red away and make it all skin colored, they perceive redness as scarring, and it's not always scarring. It's just post-inflammatory. It's just erythema from inflammation, and that can take, the better part of 6 months to a year to fade. And then they're actually not so concerned about scarring treatments anymore, because the redness just had to fade.
Great. Okay. I would wonder how everybody's doing. We're at time, but it took us a while to log in. So I think it would probably be okay to go 5 more minutes, and we can probably get most of the questions. Do you have a pen and paper there, Gabby?
Me? Yeah, I do.
Yeah. Yeah. Okay. Because I'm going to read a blitz of Accutane questions, and I think you could probably pick them off faster than me
Okay.
butting in every time. So is the triglyceride monitoring fasting? Do you ever have them sign a contract, an isotretinoin contract? Do you gradually titrate up to the daily dose? Are chemical peels okay while you're on isotretinoin? How do you manage a severe flare when on Accutane? If you still have lesions after reaching the 5 months, can you extend it? And if so, how long?
Okay.
Yeah, and that's
Those are
it
all
for the
great
Accutane
questions.
questions. Yeah.
Yeah, those are all great questions. So I'll start with the triglyceride fasting question. I'm not too fussed by it, to be honest. I think that there's a movement now for labs to do non-fasting lipids anyway. So if a patient did come in with a ragey, triglyceride close to 5, I'd probably say to them, were you fasting? Because if they weren't, I'd probably have them repeated fasting just to check. So I don't make a big fuss about how if they're fasting. I do say do a fasting blood test, but I also know that labs are telling people now you don't have to be fasting always. So I don't know if that's an answer or not, but I think, if it is elevated, it's so rare that the triglycerides are high enough to get close to 5. So rare, maybe once every 3 years do I see that. And in that case, I think I would just repeat the blood work with fasting to be sure, if they hadn't been fasting. Okay, a contract for Accutane. So that's an American thing. The Americans are obliged to use a contract. It's part of some sort of regulation they have in the States. They're not allowed to actually prescribe isotretinoin without a third party being involved, handling all of the consent paperwork. It's incredibly obstructive. I personally don't use a contract. I have a colleague who does. It all comes down to your comfort level. I'm very clear in my verbal communication about what I'm expecting from the patient responsibility wise and what the risks are. And I document all of that, but I don't do a contract. Do I titrate the patient? Yeah, I often do. So do I titrate the patient? I will often target them to 1 milligram per kilogram early. That's just my prescribing style, but I'll often have their first prescription be about 60% of that. And then I'll give them their second month right away. If they're men, for example, if it's a man or a teen, and I know I'm not going to see them for 2 months, I'll give them a 60% prescription for the first month and then target the full milligram per kilogram for the second month. And they'll often go down if they're not happy anyway. And we'll talk about that in our follow-up visit. So yeah, I will often start a wee bit low, but not half low. That's just not my style in how I do it. Are chemical peels okay? Chemical peels, okay, there's lots of different types of chemical peels, so it's a slightly complicated question, but there are certain chemical peels that will actually treat active acne. Like, for instance, a salicylic acid peel is an acne treatment because it's anti-inflammatory at a higher dose. So they're probably okay. Yeah, they're probably okay during isotretinoin treatment, because we kind of know that, most treatments for acne in the aesthetic realm can be done while on isotretinoin. They're going to have a lot of reaction for sure because they'll be dry. So the question is, what's the chemical peel for? Are you treating the acne, or are you treating pigmentation? Or are you trying to treat the scarring? Because those peels can do different things. So I think you could do a peel, but you'd have to really be careful with the concentration and the type of peel that's done, and just based on tolerability. What do you do if there's a severe flare? So if there's a severe flare, so if I didn't talk about it, but some patients come in with terrible nodulocystic acne, like just terrible. And in the beginning weeks of isotretinoin treatment, that can sometimes flare significantly. And sometimes as you start treatment, they'll flare significantly. And then there's a protocol to actually put people on prednisone, because that's the only thing that's going to calm the flare as the isotretinoin slowly starts to work, because it really doesn't work well. I mean, patients hardly notice anything the first month in terms of improvement. They'll notice things into the second, third month and onward. So you have to be patient with the treatment. But if they do flare, I'd either drop the dose a little bit and or add prednisone, and then just, push low and slow to get through that. And sometimes they have to be on, if like the really bad cases that have like terrible necrotic acne, as they start the isotretinoin, they sometimes have to be on prednisone for a couple of months. So it's a real balance. It's a fine balance in how to treat those patients between those two therapeutics, but they're still important to push forward. Then the last question I had on my list of what you just asked was, if after 5 months you keep treating, how long? In those cases, I go month by month. So let's say we've hit 5 months. I'm happy with the total dose, but they're still having acne. I'll carry on for a month and then I'll have them back. And I think my personal record is about 9 to 12 months for a few patients that needed to continue on treatment for that long, until we felt they were controlled.
Ooh, great. So we've almost got all the questions. We know we're over time. If anybody needs to leave, that's great. And we have some goodbyes and thanks for the excellent talk in the chat. But we have about 2 other questions I think we can do. Regarding sport and spironolactone, Steve Martin found out for us on the chat here, they need to contact CCES, which is some sort of organization in sports, and discuss with an advisor. It's possible with an appropriate documentation, which will need to include an expert opinion that it is needed. So that's if you got a professional or an athlete that gets tested. Moisturizer before or after topical retinoids, does it matter? And what is the dose of prednisone and for how long?
Okay, moisturizer question first. Moisturizer first, then retinoid. Because you kind of want to get the retinoid where you want it to be. And you kind of, if you're going to moisturize your face, you're going to smush the retinoid all over the place. So I moisturize first and then the retinoid. So let's say they only have acne on, say, their cheeks, and it's very little on the forehead or hardly at all. Well, they only really need to put retinoid on the cheeks, and then you want to kind of keep that localized. So I always tell people the medicine will go through the moisturizer because it'll migrate. So that's my answer to that. And what was the second question?
The dose of prednisone.
Yeah, what dose and for how long? The answer is it depends. Like, if you've never seen it, honestly, after today's talk, Google necrotic nodulocystic acne, because it's terrifying. Like, it's terrifying. what it looks like. It looks, yeah. So in those cases, they might need, a milligram per kilogram of prednisone for, for several weeks. And I don't empirically give prednisone as I start isotretinoin. If they're already having necrotic acne before they've ever had treatment, and that can happen sometimes, then I will. But those are very rare cases. By necrotic, I mean they're coming in with horrendous acne. They're already ulcerating. Those patients are going to have to go on prednisone even before they start isotretinoin, just to calm things a little bit at about a milligram per kilogram. But if they start isotretinoin and they have a terrible flare and I feel they need prednisone, then I'll probably do like 0.5 milligram per kilogram for 1 to 2 weeks, and then maybe bring it down a little bit based on how they're doing.
Great. Thank you so much. Whew, big breath. So you just did an amazing job answering those questions. It was like a game show or something, just firing them at you. We're done. Everybody, you will get a evaluation. Please take some time to do that, and you will also get notified of your CPD credits for this. And stay tuned for our next session coming up, and we'll be reaching out to you. And someone asked about a handout about cost comparisons. We'll see if we can provide something for you, and we'll send that along for the various topicals. So thanks, everybody, and thank you so much, Gabriele. That was an absolutely amazing talk, and you did so great. Have a good night, everybody.